Good day, everyone, especially to my professor, Miss Nicolene Elso Magaysay, RMT. Today, I was tasked to present to you my chosen case studies topics for the Clinical Chemistry 2. It's under the topic enzymes. We know that enzymes are specific biological proteins that catalyzes biochemical reactions without altering the equilibrium point of the reaction or being consumed or changed in composition. The other substances in the reaction are converted to products. Enzyme needs a substrate to react to. Enzyme also catalyzes many specific physiologic reactions. These reactions are facilitated by the enzyme structure and several other factors. As a protein, each enzyme contains a specific amino acid sequence, which is a primary structure with a resultant polypeptide chain twisting, and this belongs to the secondary structure, which then folds, and this is the tertiary structure, and results to a structural cavities. The general classification of enzyme and nomenclature includes oxidoreductases. So these are enzymes that catalyzes an oxidation reduction reaction between two substances or two substrates. Number 2, transferases. Transferases catalyzes the transfer of a group other than hydrogen from one substrate to another. Number 3, hydrolases. This catalyzes hydrolysis of various bonds. Lyases, on the other hand, catalyzes the removal of groups from one substrate without hydrolysis. The product contains double bond. Next are isomerases. Isomerases catalyzes the interconversion of geometric and optical or positional isomerase or isomers. Number 6, ligases. This catalyzes the joining of two substrates coupled with breaking of pyrophosphate bond in ATP or a similar compound. So much more about enzyme will be discussed in my chosen case study. But for a quick example of the following nomenclature for oxidoreductases, this includes lactate dehydrogenase, glucose-6 phosphate dehydrogenase, and glutamate dehydrogenase. Example of transferases that includes aspartate aminotransferase, alanine aminotransferases, creatine kinase, gamma-glutamyl transferase, glutathione S-transferase, glycogen phosphorylase, and pyruvate kinase. For hydrolases, this includes alkaline phosphatase, acid phosphatase, alpha amylase, cholinesterase, chymotrypsin, elastase, 5-nucleotidase, triacid glycerol, and trypsin. For lyase, that includes aldolase. For isomerase, this includes triophosphate isomerase. For ligase, that includes glutathione synthetase. My first case study is about a 54-year-old man who is admitted for an elective shoulder repair. The day before his surgery, he developed acute onset central crushing chest pain radiating to his left arm and up to the jaw. He is also sweating and feeling nauseous. He has a past medical history of coronary artery and a bypass grafting and angina or a pain in the chest. And his father died from a heart attack age 46. An electrocardiogram is performed which shows acute ST elevation in the inferior legs. He is diagnosed with acute coronary syndrome and treated appropriately. His surgery is delayed, but he presents with the same symptoms 2 days later with further ST changes in the lateral wings. The question is, which cardiac enzyme is most useful to confirm reinfarction? Is it A, troponin I, letter B, troponin T, C, aspartate aminotransferase, letter D, creatine kinase, specifically the MB or the muscle brain, and letter E, lactate dehydrogenase? This question is difficult to answer since it requires both the knowledge of the relative sensitivity of cardiac enzyme and the relative timeline of which they raised after a recent infarction. So the answer for the question is letter D. That's creatine kinase, specifically the strain of MB or the muscle and brain strain. CKMB is the heart isoenzyme. Creatine kinase, which rises about 6 to 12 hours post-infarction, and it usually peaks in concentration 24 hours later. It then reduces to normal within 48 to 72 hours. It is very sensitive. It is diagnostic if it is lesser than 6% of total creatine kinase or the CKMB mass is greater than 99% percentile of normal. It is very useful in detecting reinfarction because of its sensitivity in a rapid return to normal levels with troponin I and T. Troponin is the most sensitive and specific test for myocardial infarction. It is traditionally taken 12 hours post-infarction. Troponin I is a better marker of myocardial infarction compared with troponin T. Troponin I sensitivity is 90% at 8 hours and 95% respectively, while troponin T is 84% at 8 hours and 81% respectively. However, troponin level take up to 10 days to normalize, making their use in the infarction shoots soon after a primary infarct limited. And another reason troponin is not the correct answer is that they are not, strictly speaking, cardiac enzymes, but rather a structural protein in the contractility mechanism. Interestingly, troponin T is also elevated in chronic kidney diseases without troponin I elevation. So this was for reasons unknown. AST is not the reason because it rises 24 hours after an infarct and remains raised 48 hours, but it's less sensitive and less specific. It is also raised in liver disease, skeletal muscle damage, particularly in crushed injury and hemolysis. Similarly, LDH or the lactate dehydrogenase, which is its choice letter E, rises about 48 hours after myocardial infarction and remains elevated for up to a week. So it is not specific. It can be raised in liver disease, hemolysis, pulmonary embolism, and tumor necrosis. For a summary of cardiac enzyme changes in time, so you can refer to the following graph. So that's it. The cause or the reason or which the cardiac enzyme which could confirm the reinfarction of the said case is letter D, that's creatine kinase or the muscle brain strain. Since it rises 6 to 12 hours post-infarction and usually peaks at concentration 48 hours later. It has a longer time to be measured and it is very sensitive. And it is also diagnostic of total creatine kinase. This is also very useful in detecting reinfarction because of its sensitivity, and it can return to normal level immediately after a specific time compared to others. So it can peak at a specific time and it can also go back to the normal value fast, so there will be no errors in measuring the same enzyme level. That ends the case study number 1. The use of creatine kinase, specifically the muscle brain. So my case study number 2, a 51-year-old overweight white man visit his family physician with a symptom of indigestion and of 5 days duration. He also had bowel sores and sweating, miliase, and headache. His blood pressure is 140 or over 105 millimeter mercury. His family history includes a father with diabetes who died at the age of 62 at acute myocardial infarction secondary to DM or diabetes mellitus. An electrocardiogram revealed changes from 1 to 6 months earlier. The result of patient blood work are as follow. CK 129, UL with a reference value of 30 to 60, CKMD 4% with a reference value of greater than 60%, LD 280, UL 10222. Lactate dehydrogenase, LD number 1 is greater than LD2, AST is 35, UL with a reference value of 5 to 30. Question number 1. Can a diagnosis of AMI or acute myocardial infarction could be ruled out in this patient? So my answer is no, because AMI cannot be ruled out in this patient since LD1 is higher than LD2. So this is a flip pattern indicating either a hemolytic disease or AMI. Number 2 question. What further cardiac muscle marker could be run from this patient? So we can check on cardiac markers, specifically troponin I. CKMB is normally the marker that you will select to check for the AMI. So since CKMB is normal in this case. Number 3, should the patient be admitted to the hospital? Yes, since it must be monitored after acute myocardial infarction. Case study number 3. A 71-year-old woman is walking from home from the shopping center. She fainted and fell, and she is driven home by a friend. When home, she realizes that she is bleeding from her mouth and slightly disoriented. She appeared injured from the fall, but she does not remember tripping or falling. The woman is taken to the local emergency department. The examining physician determined that there was a loss of consciousness. To determine the reason, he orders a head CT and ECG scan and the following lab tests: CBC or complete blood count, PT, APTT, CK, CKLD, and or the creatine kinase level, LD, the AST or aspartate aminotransferase, and troponin T and I. All tests are within normal limits. The woman is sutured for mouth injuries and admitted to a 24-hour observation unit. Question number 1. What possible diagnosis is the physician considering? According to the data given, the physician might be considering arrhythmia or the abnormalities in the rhythm of the heart. MI or myocardial infarction, anemia, it could be because the person bled. It could be a possible reason also. Anemia or CBA or seizure disorder. She fainted without tripping or falling. So it could be possibly an epileptic attack, or it could also be a heart disorder. specifically AMI or acute myocardial infarction, because the ECG and troponin, CKLD, were tested. So the physician might be suspecting that it is an AMI or acute myocardial infarction attack, or it could also be an underlying condition such as epilepsy. Number 2, what lab test would be elevated 6, 12, and 24 hours if this patient has acute myocardial infarction? If the patient has a acute myocardial infarction, lab tests that would be elevated are the following. First is the creatine kinase. Next is creatine kinase, specifically the MB and the AST and the LD. Number 3 question. What enzyme test could be useful for this patient? It would be useful to test the isoenzyme of the lactate dehydrogenase, the LD1, and the LD2. Or it could also be possible the CKMB as well. So that ends my presentation for this case study. Thank you so much for listening. So I hope that through my simple presentation, some of the topics are given justice, such as explanations on why this happened to a person, what are the possible suspected cases or suspected reasons why, for example, for the woman who had fainted, and much more about the arrhythmia or the angina, the things that they are feeling in their chest are really significant, since we are measuring cardiac markers. So this involves the enzymes that are involved in the heart. So with my presentation, I hope that you had learned something. God bless you and thank you so much.